Morning, everybody, and welcome to the City of Patterson Ryan White Part A Political Quality Management Committee meeting. Today is Wednesday, April the 2nd, 2025. I appreciate everybody joining us online and in person. And for those of you who didn't come in person, you're missing the breakfast buffet. But hopefully next time you'll be able to see us. There's not a buffet. All right, quick review of the agenda. Today, we're gonna go through roll call. We're just gonna take a couple minutes there to make sure we have the right contact people. And their staff changes or responsibility change, so we make sure we're reaching out to the right people in each agency. Do welcome and introductions, since this may be some people's first time, and it's the new grant year. Report and updates from the recipient's office, and then we're gonna spend a majority of our day diving into the quality improvement project for 2025-26 grant year. It's only gonna be one project again, okay? We're gonna run it throughout the whole year, well, not the whole year, May to December. And then we'll use January and February to kind of debrief, review outcomes, and see where we want to go with the EIS program, right? Because as we've discussed at provider meetings, we'll be redesigning the EIS program to ensure that we're meeting the 4 components required by HRSA. And that we are trying to initiate a rapid linkage to care program. So that when somebody is tested positive in the field, we want to initiate what we call a rapid response team, and then find providers who will let us bring that client to them immediately, the same day, and get them linked to care. To see how that works out. That's some of the best practices we've seen across the country. We've seen people do this with ending the HIV epidemic money, which we do not have. So we're going to create a lookalike under EIS to get our clients linked to care quick. And on antiretroviral therapy to help us try to end the HIV epidemic in Patterson and Bergen Passaic counties. And if RDE is with us today, we'll have some updates from them, and then we will adjourn. There's typically a provider meeting after this, so if anybody needs to stay back and wants to work on their worksheets, my plane doesn't leave till 9 o'clock tonight, so we can go to lunch. You want to take me to lunch? I'm down for lunch. I'm playing. I'm joking. But yeah, so I'm here for the help. All right, so let's look really quickly at people who we have identified for each subrecipient. And recipient's office, if somebody happens to not be funded here that I have listed, I don't know what the new funding looks like. Has that been announced yet? For the new grant year, like the new subrecipients? No. Okay. So if by chance, okay, so we won't worry about that then. All right, Bergen Family Center. Who do we have with us from Bergen Family today?
Just Paula Tenebruso. Hi, everybody.
All right, Paula, hold on 1 second. Let me move you to the other screen so people can see your smiling face.
What's that?
I have to move you to the other screen so people can see you. Hold on 1 second. I did that. Now I can't get the PowerPoint back. Hold on. All right, I gotta move this over. All right. Oh, now we've lost Paula again. Hold on, Paula. There you are. All right, go ahead, Paula. Would you like to introduce yourself?
Hi, Paula Tenebruso from, I'm the Director of HIV Services at Bergen Family Center in Inglewood. And good morning, everybody.
Great, thank you, Paula. Good morning. And I also have Graz and Rachel Cohen listed as.
But yeah, Graz is at the hospital and Rachel's in other meetings, so you just have me today.
Yeah, no worries. But are those? Do we want to keep those other additional people on the list?
Yep.
Okay, perfect. All right, Buddies of New Jersey, Abraham.
Good morning, Abraham Corsino from Buddies of New Jersey.
What do you do, Buddies?
Operations manager, Buddies, case management as well.
Okay, awesome. All right, and do we want to keep Rick or add anybody else? All right. Capco. Let's see. I see Norman, Faustina.
And Norman, yeah, I think it's on you. Okay, it's Lesbian I, Faustina, and Lesbia. For those that don't know, we are case management / administrative assistants here at Capco, and we have our Norman. He
All right,
was just
Norman,
there.
you want to introduce yourself?
Oh, he's on the call. Oh, okay. Yeah, I'm sorry. He's on a call right now. But
No.
Norman is and our list will stay the same. Norman is a case manager here.
Awesome. Thank you, Faustina. All right, City of Passaic, I think I saw Grace. And Darlene and Luz.
Good morning, Luz Rodriguez, case manager for Passaic Alliance, and
Grace is orange, but she's with a client, so she's just listening.
Okay. Miss Darlene?
And I'm Darlene.
All right, thank you, Darlene. All right, Hackensack.
Irene Penio, and this is our new nurse, Barbara McCully.
Awesome. And we also have Mona listed. Perfect. Hyacinth, Jaden.
Hi, good morning. I'm Jaden Jackson. I'm the Regional Service Manager for Hyacinth Foundation.
Great, thank you, sir. Northeast New Jersey Legal.
Good morning, everyone. This is Jennifer Montoya, the Development Associate for Northeast New Jersey Legal Services.
Great. Thank you, Jennifer. And we still have Mallory listed as well?
Yes,
All
she's
right,
just
great.
not on the meeting right now.
No worries. Thank you.
Thank
Great,
you.
Patterson Counseling, Blanca.
Administrative assistant, and we still have Deidre as the case manager and nurse, and we have Karen.
All right, Miss Karen. All right, perfect. St. Mary's General Hospital, Miss Jeanette.
My name is Jeanette. I'm from St. Mary's General Hospital, office manager, case manager. And I have with me Cecile Oten and Winnie Bell Diaz. Right now, they're just listening because they are attending patients.
No worries. Thank you, ladies, for joining us.
Thank
All right,
you.
straight and narrow, Miss Gloria. And then team management, Monique or Michelle. All right, and also I see that Miss Miriam snuck in and didn't say anything. Miss Miriam, would you like to introduce yourself? All right, Miriam is from City of Passaic, the Passaic Alliance. And then team management 2000, Monique, would you like to introduce yourself?
Hi, I'm Monique Springer with Team Management 2000. I'm a case manager there and I facilitate groups and I do domestic violence groups over there.
Great. Thank you so much for joining us today.
Oh, you're welcome. Sorry that I'm late. I'm on 2 meetings and I'm trying to figure out how to log into them both, but I'm here.
No worries. Well, we appreciate you joining us.
Monique, where are you from?
Team Management 2000.
Team management, okay.
Yes.
Thank you.
You're welcome.
All right, so the next item up on the list is updates from the recipient's office. Do y'all have any updates?
No, thanks. No.
No, okay. And just remember, Millie is out on medical leave and should be back in 2 weeks. So if you need anything, contact Maricela or Bill. All right, the fun part. The 25-1 Quality Improvement Project. So we didn't meet last month, but we were finishing up monitoring visits, and I am pleased to announce the quality assurance chart monitoring visits have been completed at all agencies. So now we're working on universal and fiscal pieces that we uploaded and reviewing those pieces. There may be some additional questions if they are Phil or Maricela or Millie, when she gets back, will reach out to you if there's additional questions. We hope to have those final reports out by the end of May, not sooner. That way you can see those improvement areas and where we can do some possible adjustments, maybe to a quality improvement project, depending on what your outcomes are. But that's a really low hanging fruit of where you can find a good quality improvement project. Outcomes from the performance of monitoring visits. All right. So for those of you who are online, again, I will drop in the chat the link that goes to Basecamp so that you can find the documents. Oh, it's right. Never mind. Hold on. I'm gonna bring it back over so I can see Chat. Chat. Chat, all right, chat, from the folks here. Good morning, Mary. That's not it. Let's copy this link. For those of you in person, you'll still get this, you still have this link in Basecamp. But you will be able to, we'll go through the documents today in person. So we'll drop this real quick one more time in the file. Maybe we'll do a quick overview of Basecamp real quick as well. Just to remind everybody how to navigate Basecamp, how to find things that you might need. As soon as I get this link, there we are. All right. So let's do a quick run through of Basecamp. This share. Let's start to. All right, can everybody online see where we are? Yes, no, maybe so. No, can people online see the shared screen?
Yes, we can.
Thank you.
Yeah.
All right, so when you sign into Basecamp, you're not gonna have all these windows. You may have a couple if you belong to other Basecamps. But for us, we want to see, we're gonna say it CQM, Clinical Quality Management Committee. It's gonna be a box similar to this. You'll click on it and it will take you to our Basecamp land. Right, in Basecamp, you can do a couple of things. There's a message board. This message board is where I post messages about general things. The last message I posted was about the March meeting being canceled because of monitoring visits. Right? You can respond to those. And depending on the responses, when you go into your Basecamp, see how you see a number beside it? That will tell you if somebody's responded to that particular Basecamp. So for instance, somebody responded to this. Down below, we have a lot of responses to things. So on and so forth. All right. So to get back, let's say you click on one of those, to get back to the main page, it's at the top, click the clinical quality management. The blue link takes you right back to the, what I call dashboard or homepage. Good morning, ladies.
Good morning. Sorry I'm late.
No worries. The next set of boxes you should see are docs and files. There's a lot of stuff in here. All right, but don't let it overwhelm you because it's a lot of good stuff. All right. So you'll notice you probably can't see CR snap. This is where we talk about you. No, I'm joking. This is where we might be building a document before we release it. And so we can share it with us and people are like, why did you change that document like 5 times? Because it's a work in progress. This is where we keep our work in progress. So we don't confuse people by publishing documents prior to their ready. All right. However, you will see all these ones that says the client sees this. So you will see CQM committee meetings. Let's say you got bored on a Saturday and you're like, I wonder what happened at the last CQM meeting. The videos from the entire meeting, plus all documents that were distributed are in this folder. So for instance, today's meeting, the only thing that's missing is the video from today's meeting. As soon as we're done, I move it over there. It also gets posted to the website.
Oh, wow.
All right. So all the documents are here. Everything we're going to talk about today is here. I have also, how do we get back to where we wanted to be? Let's say we want to be back in docs and files. See up here at the top where it kind of parches out each section. Go back and click on docs and files and it takes us back to the main, all right? Also in GY 25-1, that's going to be this year's quality improvement project, QIP. We have already started setting up the folders for the QIP. So the first, today is what I'm calling planning materials. There's a lot of planning materials. These should help you. But this is the first time in 2 years that we haven't written the project for you. I think we're in a really good spot that people are ready to start writing their own. We've been doing this, we've been practicing, okay? We'll talk about those. Also in 25, you'll see this is the template for the QIP. All right, this is the one you're gonna fill out, and when you're done filling it out, you're gonna put it here in the proposed projects. Okay? And then, once we get the initial presentation template ready, which is like 4 or 5 slides, and you just kind of present what you're doing. It's gonna be basically a copy and paste from the worksheet. So if you did the worksheet, your presentation is basically done. You just gotta copy some of that information over. We don't make it too hard. And then there'll be some additional folders when we start getting out a little further and discussing some of the outcomes. Barbara asked earlier, she heard about those monthly reports we were doing as it related to your care continuum dashboard, right? We might make some updates, but it's gonna be a decision we make as a committee. Like what parts do we want to track based on projects, right? And so probably July, August, September, October, November, we'll start working on those reports so that we can have conversations here about what's working, what's not working. EIS, you're an EIS provider, you're going to do a rapid cycle improvement project, which is a little bit different than a PDSA. That means you're going to notice what something's not working and you're going to change it immediately. You're not going to wait to finish that cycle out and be like, oh, yep, that didn't work. Next cycle, we'll try something new. We're going to do a rapid cycle there where you're going to change it immediately and then look next month to see what happens, right? So that one's going to constantly change. PDSA cycle, you run through the whole process. And at the end of the PDSA cycle, we need to determine, are you going to keep the change or are you going to modify the change? All right. Also in Basecamp, so back to the main here, is the schedule. So as we start having things due, I'll start populating additional dates in there to kind of give you a heads up, like, hey, by this date, please upload your proposed project to this folder, or please complete the report, or whatever it may be. I put them in here, but we haven't determined that yet. But they'll be coming. You should get notifications in your email from Basecamp. Like today's meeting should have came to you probably from me a couple of times, and then also from Basecamp. So typically a day or two before, I do post the agendas in a lot of different places. They're everywhere, just to make sure everybody has access to it. Sometimes people have issues with accessing Basecamp, depending on where you work. All right. Any questions, like general overview of the sections? Hold on, let me see. Oh, and automatic check-ins, we haven't used that in a while because we started going to those reports. But usually that check-in is what that report was. Like, what does your care continuum look like? I think the report works a little better because people miss the check-ins. If you're like me, you read it that morning at 9 o'clock and by 9:15, it's out of your head, you've moved on to something else. And now you never posted your care continuum, right? However, it's a report, you have to turn that in, so you're more than likely to finish that. And this one's not going to remind you again. It's only going to tell you, ask you once. So I may let's turn that off. Let's turn off automatic check-ins. Let's see. All right, now you'll see that anymore. You'll just see those 3 boxes. And if for any reason you feel like you missed something, you just can't find it. See where it says project activity? If you just scroll down through here, it will tell you what happened sequentially in sequential order of whatever may have happened, right? So I uploaded all these items. And then goes through like what might be canceled, who responded to what. So that's kind of a timeline of what happened in that basement. All right, any questions? All right, awesome. Let's see, please this way. All right, yes.
I missed the whole training in the beginning of base camp.
That was it.
Oh.
Base camp is super easy. It's only 3 boxes to take on. All right, so let's start out with taking a look. Can everybody still see my screen online?
Yes.
Okay, awesome. Thank you. All right, so that's today's agenda. Let's start out with the infamous worksheet. All right, so this absolutely can seem very intimidating. Right, but we try to break it down so it's very easy to follow. Awesome. All right, so let's just run through it. Subrecipient, that's who you are. What agency are you at? I've already pre-populated the dates, so this is gonna be from May 1st to December 31st. Is everybody gonna get started on May 1st? No, but that's gonna be the start of our baseline data. That's where we're gonna start with data. That way we're all starting in the same place. Your project might not start May 1st, but that's where you're gonna start with getting the data out of the e-compass system, okay? CQM project staff, who is your primary and secondary on the project? And if you have additional staff working with you, if you wanna give them shout outs, by all means, right? Project details, this is where your project's gonna be. Again, project start date, project end date. Cheat and use the dates from above, May 1st to December 31st. Project location, so maybe you're a hospital system, and we know hospital systems are big, lots of different departments. If it, just list out what department it is. Next is problem. And that's your problem statement. So don't get too overwhelmed with this because I have additional worksheets that explain all this, and we're going to go through that next. All right, down below is kind of a cheat sheet. That's the who, what, when, why, where, how type thing. Like what is the problem? How do we identify that? Your aim statement, okay? So a good aim statement is to be very specific, right? Using SMART goals, something that's measurable, time effective, and time sensitive. And again, we'll go through all those together. And then what is the rationale for doing this project, right? What is a set of reasons for addressing the problem? Next is the infamous driver diagram. Some people use what they call an Ishikawa diagram, which is a fishbone diagram. But whatever works for you. I like driver diagrams, and we'll talk about that too. So that kind of directly relates with your aim statement. So what is the primary driver? What's the secondary driver? And what are the change ideas? And we'll go through those today. Next is your plan, do, study, act. Now, the whole PDSA cycle will not be filled out at the very beginning of the project because we're only in the plan stage right now, right? The next piece we'll get to is the do. So that might be June, right? Or you may have started in it. So maybe you can do plan and do, but you can't do study and act until you get some of the results back, right? And the study is, okay, let's look at our results and outcomes. And then the act is determining, are we going to keep that change idea and those drivers and make them permanent? Or do we need to manipulate them to do better? Or it just did not work at all, right? So the important piece to remember about this is a scientific project, right? We make hypotheses. Sometimes the hypotheses do not come true, right? It is not what we thought was driving this. We got to start again. Does not mean that your quality improvement project failed. It means that thought and thesis or theory did not work. You got to find something else that might be driving that problem, right? So don't get discouraged if what you thought was going to change did not change. That means we just got to dig a little deeper, figure out what is driving that negative or challenge impact on what we're trying to do, right? Like what's keeping people from coming to the clinic? So that's a very broad topic. That would be the problem, like a broad problem statement. We just got to drill down to say, maybe it's hard to find our clinic. Maybe new signage would help us find the clinic, right? Then that's how we start building the primary, secondary, and change ideas. So again, we'll only focus on the plan and possibly the do. And then the data collection piece, tell us what you're going to measure, how you're going to measure, right? And then we'll, again, remember, May 1st is going to be our baseline data is when we're going to start. And then we'll report out from there. So I know this, Bart, this might seem a little overwhelming, but I assure you when we go through the worksheets, you'll have a firm grasp.
Do the same thing.
There you go, look at you. Awesome, I figured you. All right, so the next worksheet that we're going to focus on is, and yes, I used to be a teacher, so I apologize if it seems very school work, right? So the next piece we're gonna focus on, I don't wanna pass them all at once, and y'all be like, what is going on? I think we're just the major policy. Yeah. All right. So this, okay, so this sheet. We don't have copies of this one, but, we'll go through it together. This is gonna help you fill this piece out. Okay, and then I have some category specific ones that are gonna help you go even deeper, to be specific about medical case management, referral for healthcare and support services, and EIS. And then I have a general one to help everybody else who might not be funded for one of those three categories to find something that they can achieve and sell that. All right.
So basically, there's a whole bunch of cheating.
Sorry.
Basically, there's a whole bunch of cheating.
Well, unless you can't read and can't fill out the paperwork, then you can't cheat, right? Awesome. All right, so the very first section are the project details. So this will clearly define the fundamental details of your quality improvement project. It will help ensure clarity, feasibility, and alignment with your agency's capacity. This section will set the tone for the rest of your quality improvement plan. All right, so some key definitions, right? What is the project title? And so if you're following along on this sheet as well, this is kind of explaining that piece. Project title, a short descriptive name summarizing what your project aims to improve. Okay. Next, project dates. We already did that, May 1st to December 31st. And project location, the exact site where your project will take place.
Are you gonna send this to us in
It's already in Basecamp. Guided prompts for completing section 1. So again, this will help you. What specific improvement is your project trying to achieve? Again, this is still specific about that title, right? So I kind of try to explain it a couple of different ways so it will be easy to understand. Can someone outside your organization understand what your project is about by reading this title? That's kind of what you want your title to do. Tell somebody who has no idea what you do, what your project is going to tell them. Okay? That's kind of the thought process that I use when I'm doing projects is if somebody who has no idea what we do read this, they could kind of follow along without the medical jargon or terminology, but they have an idea what we're trying to improve upon. Next, project date, so that's self-explanatory, we already did that for you, May 1st to December 31st, and the location. So here's an example of a project title, increasing rapid linkage to care for newly diagnosed Hispanic Latino clients. Right, so some of you may want to focus on what we call our subpopulations of focus, right? And so there are a specific 3 sets of individuals or demographics that we really want to address, okay? Hispanic Latino individuals is one of those, right? Those are our underserved populations. Again, we already have the project dates and XYZ Community Health Center, Patterson, New Jersey, HIV testing and counseling department. Again, if you're in a large facility, I'd just be specific about where you may be conducting the research. And then some checkpoints to finish up section 1, which is basically the very first section, okay? Does your project title clearly communicate? Are your project dates feasible? Is the location specific enough? Okay. Let's dig a little deeper. That's the easy part, right? Getting started. Next, problem statements or the 5 W's, right? So in your problem statement, you're going to want to use the 5 W's to craft a clear and comprehensive problem statements. So the who, which clients, staff, or stakeholders are directly affected? Next, what specific problem, barrier, or gaps is occurring? Gaps mean, is there a gap in service? Somebody's disproportionately impacted by a particular service category or particular thing that's happening? Is there a barrier for a particular person or demographic in getting to care? or whatever your project may be. We're looking at that. Next, identifying a win. When does this issue typically arise, or peak? Sometimes you might not have one of the W's. Maybe there's not a specific time this happened, it's just happening all the time, right? And so you could say all the time, but if there's a specific time. I know when I worked in medical for a while, we saw an influx of clients around holidays because people want to spend time with family. They want to be healthy. They want to be able to get out and spend time with people. So we always saw a lot of people coming around Thanksgiving, Christmas holiday, who we haven't seen in like 2 years, right? We're still been refilling your meds. They haven't come in because you're we keep refilling your meds. We haven't got you in for a medical visit yet. So we typically see those people around the holiday. Next, where within your system, service, or workflow is the problem occurring? All right, I'm going to keep using medical because that's the easiest one to do. So in case management. So let's say that you have a standing order for influenza vaccination between October and March. Or let's say you don't. Let's go that way. The people are coming in. Sometimes the doctor, I mean, a lot of doctors only have 15, 20, 25 minutes for a follow-up visit. I can barely ask you the basic questions. More or less, remember, do you need a flu vaccine? By the time I finished, if your mind's like mine, I had went on to the next activity already, and I forgot to ask. So some clinics initiate a standing order that says, anybody that comes in, maybe the triage nurse asks, have you had an influenza vaccination? No, you're getting one before you even leave my chair to go in to see the doctor, whatever that process may be, right? So you want to kind of look at where within your system does a problem occur. Next, why is the issue happening? What are the suspected or root causes? But this is where you could use a fishbone diagram, and maybe we'll do that at the next meeting, or a root cause analysis to determine like what is our problem and what are the pieces that go along with this cause? What could be some contributing factors and identifying why this is happening. Okay. So this framework ensures that your statement includes both context and urgency, helping you and others to understand what issues or matters and how that impacts you. Okay. So some things to think about when you're answering the who, what, when, why. So who, which population is most impacted? So is that transgender clients, Hispanic Latino clients, clients who have men who have sex with men, and also are staff also affected by the problems? So for instance, one of the reasons we redesigned case management is we were seeing that case managers are spending a lot of time doing eligibility, right? And not focusing on case management. That's why we moved referral for healthcare to do eligibility. Let case managers focus on case management, right? Let somebody else do that paperwork. Because by the time I've done 2 hours with you and getting all your paperwork together and your eligibility situated, I don't want to spend an additional 2 hours with you in creating a care plan or going through the biopsychosocial assessment or doing those type of activities. All right, so that was kind of redesign that. The next is the what. What is the exact issue you're trying to improve? Is there a measurable gap or trend, right? Is there low retention? Is there delayed linkage to care? Is there missed follow-up appointments? Like identify what that gap may be. The when, at what point is the service process, does the problem occur? Is it ongoing or does it spike during specific times? Where is this happening? Again, specific locations, clinic. Is it happening in the intake process? Is it happening in the referral process? Is the referral process not happening at all? Or is it happening in the eligibility system? Those aren't the only ones you can choose from. Those are just examples of where the process might be working now. And then finally, why? Why do you suspect, what do you suspect are the contributing factors? This is kind of where we're making our hypothesis again. What's contributing to this? So doing a root cause analysis would definitely help. And are there known causes like staffing challenges, documentation burdens, or communication gaps? Maybe there's an administrative burden to you being able to be successful in service delivery, okay? So here's an example of a problem statement. Hispanic Latino clients newly diagnosed with HIV at a community-based testing site are experiencing delays of more than 7 days in being linked to HIV medical care. These delays often occur during the handoff between testing staff and case managers. Root causes may include limited bilingual staff, unclear referral protocol, and lack of real-time communication between agencies. See how we meshed the who, what, when, whys all together into one statement? That tells you everything of the 5 W's of what our problem is. Does that make sense? Okay. Reflective checkpoints, again, before moving on to your, before finalizing your problem statement, right? So, does your problem statement identify who was affected and how? Have you included measurable indicators or specific observations like number of days delayed or percentage of clients affected? Have you identified a root cause, right? So I think maybe June, I'm way ahead of myself. April,
yeah.
right?
Yeah.
Never mind.
Trying to skip May already.
For some reason in February and in January, I didn't think there was a February. I kept going to March, and then March, I kept wanting to call it February. It was really weird.
I see.
Yeah. So, and maybe in May, we will absolutely work on a root cause analysis together to see how to do that. And maybe we'll make the due date if people are having problems finding root causes. If not, then we'll just still submit in May, and we'll just do the activity anyways, so that people are more recall. Again, it is your problem statement narrow and specific enough to be addressed within the 8-month project period. All right. All right. Section 3. Right. Aim statements. Okay. Here, how many of y'all have heard SMART goals? Right? SMART, SMART goals. Specific, measurable, achievable, right? So now, even though the government doesn't recognize it, I like, in the last 3 years, I like to use SMARTY goals. Okay, SMARTY includes inclusive and equitable. Right, so not only do they need to be specific, measurable, achievable, relevant, time bound, but now they also need to be inclusive and equitable. Let's read through that. So your aim statement defines what the success looks like. It should be bold, measurable, time-bound, and directly aligned with the core issues you've identified in your problem statement. The SMARTY framework ensures that your goals also explicitly promote inclusion and equity. So while the government may be getting rid of this, we are not.
Because that's what, I'm gonna get into it.
No, you're fine.
That's what we use, the SMARTY goals in, HPG's,
Yep.
videos.
Awesome. That's very good. Thank you all for not getting rid of that.
Because, when it comes down to that, like, especially with integrated plan, and, the priority settings, every committee meetings, we use the SMARTY goals.
Very good, very good. And SMARTY is important because we're not designing processes for just a specific population. Like our project may be about a specific population, but it's designed for it to be equitable across the entire, right, service delivery area. So while we may be doing a specific project about a certain demographic, the outcomes need to be measurable across the entire board, right? And equitable for everyone. So inclusivity ensure you're considering diverse perspectives, especially from those most impacted, and equitable focusing on closing gaps or addressing disparities in healthcare. Right, so you're looking at your care continuum, and you notice that Black and brown people have a lower viral suppression rate. Right? That's a fact.
That's what the basically the main goal is, to make it, get everyone, I was different for some time. Undetectable.
Yes, ma'am, undetectable, absolutely. All right. So again, the SMARTY goals will help you create your aim statement. When you're thinking about those, is what exactly will your project achieve? What do you want it to achieve? Clearly define the population process or outcome you're targeting. For measurable, how will you know the goal's been met? Right? sometimes we say we do our baseline data, our viral suppression rate's at 57%, maybe our goal's 70% by the end of the 8-month period, right? So that could be measurable. Also, what specific metrics will you use? Are you going to use percentage of clients linked to care? Are you going to use viral suppression rate? Like, what piece of that are you going to measure? Achievable, is the goal realistic for your team? So if you're at 57%, probably putting 99% viral suppression rate is not, it's not going to be an achievable goal. It could be, but it doesn't seem very realistic to go from 57 to 99 in 8 months. Unless you just know it's like a huge data problem, you just haven't put the data in. Then maybe by all means you could. But 57 to 99 is a huge, so make it achievable. Relevant, how does the goal align with the client's needs or the agency's priorities or the TGA's priorities? What organizational community challenges does help to address this issue? Time bound, when will the goal be achieved by? So again, remember our period is May 1st to December 1st, or our goal is by December 31st. Inclusive, who will be involved in the planning, implementation, and feedback process? How will you ensure participation from priority populations of people with lived experience? So maybe some of you have CABs, right? Community advisory boards, or you have some type of an advisory board, or you have a client board or patient board. Maybe this is something you could present at one of those. Talk about like, hey, this is a project we're doing. You're more than welcome to also come to planning council. If you want some input or feedback, come do a presentation for us. Talk to us about the project you're working on and how that may impact clients. So you're more than welcome to use us as a focus group as well.
Which I always do with both, cause I'm in both, cabs. I'm in, Rutgers and in, Hyson cab.
Oh, awesome. Okay, great. Very good. And then finally, equitable. Which disparities this project aims to reduce? And how does the goal help close gaps in outcomes for underserved populations and communities? So an example of a SMARTY goal, and remember, it's got to be very specific. By December the 31st, 2025, we will improve viral suppression rates among transgender clients from 65% to 80%. By implementing culturally responsive adherence counseling and peer navigation services. We will engage transgender clients through peer-led support groups and include their feedback in program adjustments. This goal aims to reduce the viral suppression disparity between transgender clients and the overall population. So even there, like when you're talking about your report out at the end of the year, you could say, hey, look, we went from 65 to 80 in our transgender group, and in our regular population, those who are not disproportionately impacted, it stayed the same. So we've made it, and maybe is that something that you could also do to your regular population now? So maybe your next improvement project is to expand that to the entire population that you're serving, right? All right, any questions about, checklist before you finalize your SMART goal and your aim statement, okay? Have you clearly identified who and what the goals target? Is the goal measurable, achievable? Is it time bound? Does it support the agency's mission or the TGA's mission and priorities? Have you included strategies to ensure voices from impacted communities are heard? And have you clearly stated how the project will help reduce disparities? Those are the takeaways from that piece. 4, any questions about that section? All right, so if you're following along, now we're on rationale. So we went through the driver diagram. We're going to get more specific in the driver diagram when we start looking at the other set of needs. So right now, we're at rationale. Oh, sorry, we got there. Above rationale, above driver diagram. My apologies. I got ahead of
I thought I had a little brain for this meeting.
No, I didn't even know. We're on rationale. My apologies. Page 2. All right, rationale. Your rationale explains why the quality improvement project matters right now. This section should connect the dots between the problem, the goal, and the impact on client, staff, and their agency. A well-written rationale strengthens the urgency, strategic relevance, and equity focus of your project. So some key definitions about what those things mean. Rationale is a clear evidence-informed explanation of why you are pursuing this project and how it will make a difference. Urgency basically answers why now? What is driving the need to act quickly? Is it a health disparity? Maybe you have a cluster incidence group in a certain, location that you happen to be serving. New data or some just missed opportunities. Strategic alignment. How does this project support your agency's mission and or the Ryan program goals, or just a broader public health priorities? And finally, client and community impact. How does this project improve health outcomes, service access, or equity for clients across the entire community? So the things to think about for guided prompts as you start answering the rationale section. Why is it important to address the problem right now? What are the consequences of not acting? Right, so we have a new cluster of people being diagnosed with HIV, and it has to be one of the clusters where it's just like people sleeping with people, and it's just, you all know cluster grouping. Okay, awesome. I'll explain that. So maybe you have a cluster that you have to address immediately, figuring out what is happening in this particular area. Okay. Maybe you have just a particular case manager or a referral for healthcare person who's not doing eligibility correctly. And so you're looking at the paperwork, you're missing proof of income from everybody, right? So just identifying what a problem might be. What is the impact? What impact will the project have on client outcomes and health equity? Will the project reduce the known disparity? Will it improve quality of care, service access, or retention of care? How will your staff or agency benefit from addressing the problem? Will the project reduce workloads, improve workflows and clarity? Right, so we're hoping referral for healthcare is going to help, one, reduce the workload of the case manager so they can focus on case management and not asking Abraham to bring his proof of residency in like 7 times. Right, he can come to get a bus pass, but I cannot get you to bring your proof of income with you. Right, so thinking out loud. And will it also help support staff morale or some type of capacity building? Next, how does the project support your agency's strategic goals or the Ryan White priorities? Does this connect your agency's mission, performance, or prior clinical quality improvement findings? Is this part of a broader goal? Like, is this part of ending the HIV epidemic, right? Community planning or equity improvement? So an example of a rationale statement. This project addresses persistent delays in linkage to care for newly diagnosed Hispanic Latino individuals, clients, a disparity confirmed by quarterly performance data. So where did you get the data? If left unaddressed, the issue risks worsening health outcomes, increasing community transmission, and weakening trust in the system. By improving coordination between testing partners and our medical case management team, we expect to reduce time to linkage, boost viral suppression, and improve cultural responsiveness. This project supports our agency's equity commitment and aligns with BPTGA's priorities to address disparities affecting Hispanic, Latino, and transgender individuals. Right, so there's a lot of thought process put into this. But if you follow the steps, you should be able to come up with some really great rationale, aim statements, and problem statements. So before you finalize the rationale, have you clearly explained why now is the right time to act? Have you described how the project will improve client outcomes or equity? Have you highlighted the operational staff benefits that build in the turnover support? Have you tied your project to your agency or the Ryan program or local health priorities? And does your rationale inspire action and clearly justify the project's importance? Questions? All right. Driver diagram is a powerful visual and strategic tool that shows how you plan to achieve your project. It links your aim statement to the key drivers or factors that influence success and the specific change ideas we'll test to make improvements. So again, an aim statement, we did that earlier, section 2. The specific SMARTY goal you want to achieve, section 3. Primary drivers, the major factors that directly influence the outcomes you're trying to improve. Secondary drivers, the specific component or sub-factors that influences each primary driver, and change ideas. This is a concrete testable strategy you believe will move the needle on your drivers and ultimately change the aim or achieve your aim state. Think of your driver diagram as a roadmap of what you plan to influence and how you plan to do. So let's look at that. Well, guided prompts. As you're starting to develop that, restate your aim statement. So on the side, you'll see blank on the aim, right? You put that, you just recopy your aim statement underneath. Identify primary drivers. What are the big systems or processes that must work well to achieve your aim? And consider categories like communication, coordination, training, client engagement, workflows, policy, and documentation. What are parts of those to change to help achieve your aim? Secondary driver. What specific steps, tasks, or behaviors influence the thing above, or primary driver? And these are smaller parts of the process that, if improved, will strengthen your primary driver. And then finally, generate change ideas. What actions or interventions will you test to improve your drivers? And then, are your change ideas small, specific, and feasible to implement quickly? So again, let's look at what our aim statement is, and we'll look at some drivers. We'll look at specifically some of the service category specific drivers. So our aim statement again is by December the 31st, 2025, reduce the average time of HIV diagnosis to linkage to care for Hispanic Latino clients from 7 days to under 3 days. Right? The goal would be same day. Best practice is 72 hours. But let's definitely get it down from a week to 3. Primary driver 1. The primary driver is timely, clear communication between testing sites and case managers. Right? Secondary driver 1 is real-time electronic referral systems will help that primary driver, right? And staff training on urgent referrals will also help the primary driver. The change idea of this is use a shared referral form with timestamps and train intake staff monthly. So the way I like to read these is from bottom up, right? Once you get it developed. So our idea is to use the shared referral system from form with timestamps and train our staff monthly. We'll use that referral system and that training, and then that will affect that timely, clear communication between testing sites and case managers. So high level, smaller, more detailed. Yes.
What's PDSA cycle?
Yeah, Plan New Study Act. We'll look at that in section 6.
Okay.
Okay. Great.
Yeah,
So again,
learning as I go.
you're good. The more specific idea is the change idea. So if we use a shared referral system with timestamp, that is going to help us with real-time electronic referral systems, which in return is going to help with timely, clear communication between testing sites and case managers. Now we have a form and we have a timestamp. So maybe the original thing was we weren't calculating the days for average. We really were getting it in 3 days. But we didn't have a way of determining that because we didn't have a referral system. We didn't have a timestamp. See how that works? Like specific, and then it kind of worked backwards. All right. The next primary driver. Availability of bilingual, culturally responsive navigation staff. So the change idea here, I'm going to skip the secondaries real quick. The change idea here is if we hire peer navigation or navigators from Hispanic community or develop new intake materials in Spanish, will help us with culturally relevant onboarding materials and recruitment and assignment of bilingual navigators, which in return will help with the availability of bilingual and culturally responsive staff. Right? So you get your high idea and then you drill it down like what specific things can we change to get the main idea addressed. And the main idea is the availability of bilingual, culturally responsive navigation staff. To do that, we're going to hire peer navigators from the Hispanic community and develop a new intake materials in Spanish. Right, so that's the thing we're going to measure. How did that affect that primary driver? Right. So before finalizing your driver diagram, and that's this big block here, primary, secondary, and change idea. You only need 1 or 2. You don't have to have 3, 4, 5. I suggest no more than 2, so that way you're able to track and measure that. Does your diagram clearly connect the aim, drivers, and change idea? Have you focused on factors that are within your control to change? All right, so you wouldn't want to say every Tuesday between 9 a.m. and 1 p.m. it will not rain. We cannot, that's way out of our control, unless you're him, I don't know. If you are, let us know. Right, so there's not that much we can do about that. So make sure that they are within your control to change. Are your primary drivers logical and actionable based on the problem that you've defined? Do your change ideas reflect input from staff and or clients? And are your change ideas small enough to test in a PDSA cycle? Plan, do, study, act. Okay, we're gonna look at that in section 6. Any questions? Well, section 6. So plan, do, study, act, the PDSA cycle. Right. PDSA cycle is a structured step-by-step methodology for testing changes on a small scale. Right. It allows you to implement and improve ideas, assess its impact, and adapt as needed before scaling up. This section helps you document the entire cycle for initial planning throughout the evaluation process and next steps. Again, key definitions: plan. You're going to develop your change idea, which you did in your driver diagram, and outline the details of who, what, when, where, and predicted results, which we already did that, right? Section 1, 2. And do, you're going to carry out the plan and document exactly what happened. Remember earlier I said, when you're filling out the paperwork, you're only going to do the plan and do for right now. Because the do part is exactly what it says. Now you have to develop the process that you identified, start putting that into action. So maybe every time somebody walks in, you automatically make a food shop. Right? That's going to be the do. And then the study and act towards the end of your project, you're going to analyze the results and compare them to your predictions. Right? What did you learn? Maybe something didn't work, but you thought it. And then finally, act, decide what to do next. Are you going to adopt the change because it did work? Are you going to adapt the change because it needed a little bit of tweaking? Or are you going to abandon the change idea and say, this didn't work, we're going to come up with some new items? Okay. PDSA cycles are meant to be quick and iterative. You know, we're making this a little longer than typical. We usually do this in 6-month periods, but I feel like just having the opportunity to talk about it, analyze the data together, what the next steps are, what worked, what didn't work in January and February really does help us finalize. It's a really good quality group. Right. So some guided prompts to think about when you're going through the PDSA cycle. Again, for the beginning of the project, we're only going to focus on plan and do. Later, we will do study and act. The plan, what specific change will you test? Who is responsible for the implementation? When and where will you test the change? What do you predict will happen? And what data will you collect? How will you measure the success? Next, do. What did you actually do? Describe the steps that you took. Did everything go as planned? If not, what changed? Were there any surprises or barriers? And did you document an early observation or reactions? Again, we'll come back to study and act once we get to that part of our project. So examples of plan and do. Testing, test assignment a bilingual peer navigator to all newly diagnosed Hispanic Latino clients. The prediction is that 90% will link to care within 3 days. So if we give them someone who is bilingual and speaks their language at initiation, our prediction is that they will be linked to care within 3 days. The data piece, we're gonna document the date of diagnosis versus the date of first medical visit. Right? Next, to do, assign peer navigator to fit clients at XYZ clinic, right? You don't have to do everybody. But for this project, we're gonna track the first 10 Hispanic or Latin individuals who are tested positive. Or if you're not doing a specific demographic, you're gonna take the newly diagnosed individuals in the month of May or June, or July, right? Be specific about where you get the individual. So the do is assign your navigator to 10 clients at XYZ clinic. You track the referral handoff times and navigator follow-up. Again, the studying act is after you've done those 10 clients. And so that will be towards the end of the project when you analyze what took place. So checklist is, do you document each step of the cycle clearly? What's going to happen? And are your, that's it. We'll look at the other ones towards the end of the project. Data collection, we'll come back to. That's when you're, after you started implementing your project. So we'll come back to this and how to collect your data. So make sure you're measuring, related to your aims, related to your driver, baseline tracking, etc. All right, so that will at least get you started on filling out the beginning of your quality improvement project or PDSA cycle. Any questions about those worksheets? All right, so the next one let's take a look at are for those agencies who provide medical case management service. All right, so medical case management. So what I tried to do is come up with some get medical case management agencies brainstorming along with the new type of case management we're doing, okay? So again, this still aligns with quality improvement projects to help kind of focus there. Section 1, choose a focus area with context and examples, okay? So choose one or more priorities. Are you going to improve viral suppression for clients not virally suppressed within 6 months? That's assuming the person is coming into you new, which would mean they are newly enrolled in a case. Okay, they could be diagnosed, return to care, transfer care. Okay, might be an opportunity to give yourself a little bit of a cheat point when somebody's moved to the area and they're virally suppressed. Might give you a good starting point, right? Well, we know people who are newly diagnosed typically are not coming in virally suppressed. Next, are you going to enhance client retention? Reduce missed visits, re-engage lost to care clients. Those are some ideas. Reduce documentation or eligibility delays, right? Increase frequency and quality of adherence counseling. Strengthen clinical coordination between medical case managers and providers. Okay, why does each of these areas matter? Let's talk about that. Increased adherence counseling frequency. Why it matters. Clients with less than, that's a less than sign. You remember that because the Pac-Man eats the bigger number.
Yeah.
I think I still remember that from elementary school, right?
That's
Pac-Man eats the bigger number, that's less than.
Less than, yep.
Less than 2 documented adherence sessions in a 6-month show lower viral suppression rates, right? So people aren't coming to their meetings with their case managers or viral suppression. They're more than likely not virally suppressed, not engaged. Right? They might be going through the motions, but they're not engaged with someone. All right, possible way to measure this or possible metric, percentage of clients, medical case management clients receiving greater than 1 adherence contact a month. Right? So if you remember in the new case management system, we specifically spelled out how many times or how often a case manager is to contact clients based on their need. Right? They're high acuity, high need. The contact period is at least once a month. Medium, right? I think that's cars 3 and 4, right? Believe. Sorry, Abraham, cars 3 and 4 are the highest acuity, right? Okay, so cars 3 and 4, high acuity, once a month contact. Lower acuity, a 2, once every 3 months, once quarterly. Cars 1, you're virally suppressed, you have limited needs. I am not gonna call and bug you every month, because I don't want you to disconnect from me. But I still want you to know I'm here for you. That's like once every 6 months. Let's have a couple conversations, yes. No, so somebody who's new to care will automatically be a 3 or 4. Automatically should be 3 or 4. You don't know the system. You don't know the services we provide. You should automatically be a 3 or 4. At least for 6 months. All right, so enhanced retention, why it matters. Again, some ideas we can think about. Clients who miss greater than 2 appointments in a quarter are less likely to achieve viral suppression. Again, that just speaks volume, not engaged. All right, real idea. Assign peers to conduct re-engagement outreach within 72 hours of a missed appointment. And Jetica didn't call me back. I gave her 3 days. I'll call her in 3 days. I'm gonna give you some time. I'm gonna leave you a message. But after 3 days, if nobody's heard from you, we're gonna call again. Maybe that's the process, right? Maybe Irene was supposed to return my email with her proof of income. I haven't heard from Irene in 3 days. I'm gonna email Irene again, like, hey, where's your proof of income, right? Just stay in contact with that client. Let them know you're there for them. All right. Section 2, decisions to make before finalizing your focus. Answer the question, is this issue affecting greater than 10% of your case management load? So, as you're thinking about like your aim and your rationale, this will help you kind of define better some ideas of how to come across, how to identify a problem, how to identify a rationale or an aim statement for medical case management specifically. All right. So, to answer the questions, can you influence this area? Is greater than 10% of your caseload being affected? Does the focus directly align with disparity? Will success reduce racial, ethnic, gender, or linguistic gaps in care? All right. Section 3, your SMART goals. And this is just another way of being specific. I'm not going to go through the whole one because not everybody's funded for case management. But for those of you who are, please visit the case management piece. Okay. The next one we're going to look at, same document, but thinking about referrals for healthcare and support services. So what are some focus areas that you can do in referral for healthcare and support services? Number 1, first checkbox, you can improve eligibility process and verification, right? So this is our first year that referral for healthcare is going to do eligibility. So I wouldn't make that one as time bound because you don't really have a baseline data for how long does it take the average client to complete the eligibility process. And we'll say it again for those of you who have referral for healthcare and support services. I think this would be a great project. How long from initiation of eligibility to the completion of that eligibility process does it take clients? Grab 25 clients and document from start to finish how many days it took to complete that process. And that means like, oh, they didn't bring your proof of residency, so we're waiting for that to come back. I wasn't able to get your labs yet to verify that you are HIV positive. So you're documenting all of that from start to finish, right? Some people are going to come with everything. Most are not. So that's a good starting point for your baseline. And then by the end of that project, you'll have a really good baseline to do another project in the next year to say, okay, the average amount of time it took us in 2025 was 14 days. We want to reduce that to less than 5. Now you have a baseline. Then the next set of 25 people that come in and do eligibility, you baseline them, and then you compare the two. Does that make sense? It's kind of how you can do that. Some other areas for referral would be increased successful referral completion, right? Because this is going to be a new thing. Referral's going to have to send out referrals for services through the e-Compass system. I will say more so than we do not follow up on those referrals sitting in the e-Compass system. So system-wide, that recipient and I will be working on is training on how to close out referrals, how to respond to those referrals, how to do those referrals, how to close them, and all that good jazz. So that will be our internal process, right? But learning how to use it will be yours. Strengthen follow-up system, improve collaboration, and enhance accessibility to referrals. All right. Again, it explains to you why these things matter, just as examples. You can pick these, you don't have to. But these are just some ideas to get your brain thinking about it. Next, EIS. So let me also say that if you are funded for medical, referral, or EIS, we're asking you to pick one of these to do a project in those systems, right? So if you're only funded for medical case management, your QIP will be medical case management. If you're only funded for referral, your project will be referral. If you're only funded for EIS, your project will be EIS. And when I say only EIS, if you're funded for one of these, or if you're funded for more than one, you get to pick medical, EIS, or referral. If you're only funded for one of these, that's yours. You could be funded for other things. If you're funded for one of these 3, we're asking you to pick one of these 3. Okay? Next is early intervention services. There's some ideas. We talked about, this was a lot of my example in the original worksheet packet because this is a project that we want to work on this year. This is a project we talked about in the grant application, that we were going to make a standalone lookalike rapid start EIS program. So we'll be talking with some agencies who are funded for EIS to do a pilot program of what we call rapid response team. And that rapid response team is going to work system-wide in that, let's say Angelica's testing agency has tested someone positive, they will immediately reach out to the rapid response team. That rapid response team already has MOUs in place. So I can go to Angelica, pick up the client, and take them immediately to the doctor I have an MOU with, and they are linked to care within 24 hours. That's our goal. We're not diagnosing thousands of people in this jurisdiction, right? We're only diagnosing about 68. I'm sure our medical providers can find one appointment every blue moon to get a client in immediately to either do confirmatory testing, or if they are comfortable with initiation of ARTs, doing so, right? We want the client linked and on meds as soon as possible. They have a better success rate, right? So some of the ideas we can do is reduce time to linkage for newly diagnosed individuals, improve documentation and completion of all 4 EIS components, strengthen coordination of community testing partners, increase cultural and tailored education for priority population, or improve navigation into Medicaid supporter services, right? That's what EIS is idea. That's it's for me, it's case management intense for 6 months. Like I'm doing case management, I'm teaching you how to navigate the system, and teaching you about your new diagnosis. All right, so again, some ideas. Let's say you pick the reduction in time to linkage, why it matters, how you can possibly measure that, and some real world ideas, like maybe signing a linkage navigator to see same-day testing alerts from CBOs, right? That's what we're saying, that rapid response team. Like Abe tests somebody positive, Abe knows he's supposed to call Michelle immediately. Michelle immediately dispatches the rapid response team. They do not leave you until you're done with the doctor and have your next appointment. Right, and that's all reported back to your EIS worker and or case manager. Okay. Questions about the EIS? Again, those are in your packet as well. And then finally, I tried my best To, oh, I should pass out, the items. Pass those out. For, yeah, I'll pass them out.
Thank you, Professor.
You're welcome. All right, so this one is a general question. So the idea is this, you're not funded for medical case management, you're not funded for referral for healthcare, you're not funded for EIS. You're an agency who may be legal services alone. You may be an agency who provides outpatient ambulatory and some transportation, right? So how can we get you involved in the same process? All right. So again, when we're thinking about section 1 and identifying your service categories, so you can write your service category in there, or whatever one you think you might be doing. Here's some ideas for areas to focus on. Improve client linkage to your service or other services. How can you improve more referrals to your service? Enhance retention and engagement in your service, right? Maybe you're providing legal services. People just aren't following up with you, and you say like, hey, come back and see me in a month. They're not following up. Increase impact of your service on viral suppression. That's the project we've been doing, your viral suppression rates and how that service you're providing is affecting viral suppression. Improve coordination referrals or address barriers faced by specific priority populations. Right? So maybe you see, I don't know, I'm making this up. A low rate of Latino individuals who are willing to take the flu vaccine or shingles or HPV, whatever vaccination may be. But it's among a very specific population. There could be some cultural things there. Like how do we address those cultural barriers to increase that immunization rate, right? So just again, some ideas specifically for outpatient ambulatory. This isn't all, these are just things I can honestly keep up off the top of my head when I was making this. Reduce medical visits by initiating some reminder calls. Improved antiretroviral initiation within 7 days of an intake. And that's kind of dependent on how quickly your lab can get things back. So that one might be out of your control, might not be a good project. Increase coordination with medical case management for clients who are not stably linked. So you have that handful of clients, I know we all do, who are less likely to come in and stay linked with either medical or case management, but usually one or the other sees the person often. And so if you're realizing like Thomas is seeing my medical case manager, but he's not coming to the doctor, maybe that particular linkage and coordination with the case manager will help. So we're thinking about mental health treatment and substance use treatment, some other service categories. Improve warm handoffs from medical case manager to behavioral health. Increase follow-up rates after the first counseling session. I don't know how many times I've seen a client come in, do the initial intake, right? Do the initial assessment with a mental health or a substance use behavioral therapist, and you do not see them ever again. They decided, nope, not doing it. But then you see them back in 7 months and they come back to the doctor. We try to engage you in mental health or behavioral health and substance use. They'll do that first intake again and gone. So what can we do there? Improve the linkage. Maybe do warm handoffs. Don't leave it up to them to try to go follow up. I'm going to follow up with you. We're going to walk together. Increase follow-up rates, reduce missed appointments, Utilize the PHQ-9 scores to track depression impact. Right, do that PHQ-2 comes positive, you do PHQ-9, maybe use the score from that and see how the impact of that is affecting care. Improving linkage compliance for completing detox, increase provider and case management, case conferencing. So involve the case manager in that process, right? Let them know that Thomas is coming to mental health or behavioral health and substance use treatment. So especially if there are two different agencies. So that way that case manager can add that piece to their care plan. Say, you and I are going to follow up with your behavioral health specialist or your substance use specialist to see, are you engaged? If you're not engaged, I'm going to help you come up with ways where both medical case management and behavioral health. So come up with ways to help you be successful at that. Maybe medical case manager is going to make sure they schedule the Uber for them on every Tuesday. You know what I'm saying? Like coming up, so please coordinate with your colleagues to make sure that you can do that. So that's my rule. People who provide health education risk reduction, maybe standardize a curriculum focused on antiretroviral therapy or U equals U. Improve participant follow-up on referral for outpatient and medical case management, or increase health education. HERR access to Spanish-speaking clients. Maybe you need some materials in Spanish. Maybe you need a bilingual staff. Right? So maybe that could be a good quality for your department. Food bank, improve timeliness of initial food delivery or pickup, however you may be distributing those vouchers or baskets or bags. Monitor nutrition status for medically complex clients. Right? Don't fill the bag with chips and candy and things that I would pick if I went to Walmart, right? Let me pick the stuff for you and say, these are healthy options. Right? Don't let me come back with Fruity Pebbles, right? Come back with something that's nutritious. I'm just saying, right? That happens. Somebody gave me a food voucher, I'm probably gonna get me some soda, right? So maybe you initiate a process of, we're not being punitive, but I wanna see your receipt to see if you made good choices. We're not saying you can't buy things, but you can have a conversation about like, maybe next time only get 2 boxes of Twinkies, maybe not 3. Right? Just making improvements, making good choices. Left up to our own choices. We don't always make good choices. All right, next, so let's look at legal services and how we can do some legal service. Reduce time from referral to service appointment. So if that's an issue, that's a good project. Track housing related legal interventions that improve stability. Again, I don't know what kind of legal issues that Northeast New Jersey Legal is helping with. I think some of them are probably housing situations. And maybe increase legal intake completion rates among Black and brown clients. Depends, I don't know. Maybe I made all these up. I don't know if that's even an issue. But these are just some ideas to think about of how you can initiate a project outside of the specifics I gave for medical case management, EIS, and referral. Again, it also goes through how to make a strong focus, SMART goals, how to do some drivers. Let you practice in this worksheet as well in doing your drivers. So again, I think it really kind of helps everyone. Yes, ma'am.
I got a question about legal services. I don't know if it's the right place to ask about this. When it comes down to legal services, can consumers go to legal services to talk about like legal wills or talk about housing situations or housing stability and stuff like that?
Great question. Jennifer, are you still with us?
Yes, I'm here.
Did you answer that?
I'm so sorry. Can you ask the question one more time?
Is consumers can come to legal services that to talk about living wills, if that's
Yes.
if that's okay, living wills or housing stability. Like for example, I'm going to use my place of residence for example. When it comes down to housing stability,
Like eviction.
like evictions or
Yes.
health codes or et cetera, like other, things like that, we could always go to the legal services to talk about those things, correct?
Correct.
Okay,
Okay, there you go.
okay. But I didn't know if this was the right place to ask that question, that's why.
I can ask that, yeah.
So
Oh.
we definitely provide different areas of law. We do housing, we do public benefits, immigration, tax law. We do different kinds, senior law, elder justice. So definitely if you guys need legal services or any of your clients need legal services, they can definitely reach out to us. We cover Bergen, Passaic, and Hudson County.
Okay, and this is Jennifer I'm talking to?
Yes, correct.
Okay, I'm gonna get in contact with people because we need to talk.
Okay, perfect.
Oh, okay, thank you.
Thank you.
All right, well, that is the overview of the quality improvement projects. There was a lot to take in, so definitely visit again base camp. So you can get those documents. Again, I'll show you, pull this over. It's in docs and files under 25-1 QIP. And you will see a place that says planning materials. And all of these documents are in planning materials. So please check that out. All right. So that was, let's see. So let's, our next meeting is May 7th. So I would ask that if everybody could possibly, I'll put a reminder in the calendar, get your quality improvement project worksheets uploaded to Basecamp by May 2nd, which is a Friday. I usually hate Friday deadlines, but I will give you the weekend to look over them. But by May 2nd, and I'll put in, again, I'll put a reminder in that calendar. I'll post in Basecamp as well. But we'll upload them by May 2nd. And then on May 6th, we'll talk about them some more. So I'll have some ideas how people did, if we need to send some back to get some revisions. And then on the May 7th, we'll talk about doing a fishbone diagram or a root cause analysis. So that will be our activity for May. And then if projects are returned in May, we'll ask you to resubmit them by June. And then in June, we'll also ask you for your initial presentation, which will basically be a PowerPoint that's been copied out of your worksheets. To kind of tell, and kind of give everybody an idea of what your agency is working on with your project this year. And then starting in July, we will look at outcomes and start working those spreadsheets of outcomes related to your specific project, like tell us what's happening, how you're tracking it. And then we'll go up with some more additional training opportunities based on what we hear. Do we have a site visit this year? Do we have a site visit this year? I thought I remember from HRSA. Didn't HRSA announce a site visit?
Now this time we're gonna go to.
Yeah, it was September. Okay, okay. They're coming, so it's probably gonna be next year. I have site visits already in Las Vegas and Phoenix. Next week.
I think for this year, we're actually going to.
Yeah. But I'm saying they're coming, so it's gonna be right next year.
Yeah. 6th to 9th.
Yeah. All right. Are there any other questions about quality improvement projects or worksheets? Hearing none. Any other, is RDE with us by chance? Any updates from RDE? All right, I don't see any. All right. Well, that's all we have today. So thank you for, yes, sorry.
With regards to the RDE, that's the e-compass?
That's the people who,
Okay, how, I know I filled out the long application to apply. But do I get a password? How do I get myself into e-compass? Billy had asked for her credentials, but We have to give the addition.
Yeah, there you go, yeah. Millie has to approve that.
So Millie has to. I said, email, but.
Okay, she's probably not gonna respond when she gets back.
No problem, I just want to make sure I wasn't on my end, because I
No,
said,
ma'am,
let me
okay,
try to make a new account, and it was asking the same. I said,
got you, okay,
Okay,
good question, yep, we have to wait for Millie to get in.
okay, no problem, thanks.
All right, anybody else with any questions? All right, well, I appreciate everybody coming in person today, and those of you who joined us online. I look forward to another successful year of quality improvement projects. And maybe by the end of one of these, we all can do an article for a journal on your quality improvement project that you can share your best practices with someone else. So that would be the goal for 2 years from now. People to be able to publish or do a poster presentation at a conference on one of your quality improvement projects. All right, thanks, everybody. Hope you have a great rest of your week, and we will see you again in a month.
Thank you.
Thank you.